AC joint, okay? So anything that's up into here, okay? Now, the AC joint, which way can it dislocate?
AC joint?
AC. It can go superior and inferior, okay? So it can go up, and it can rupture and go up, or it can rupture and go down. So when you're looking for AC, your biggest point for AC joint is really palpation, okay? Special tests are kind of helpful for your grade 1s, but for most of your ACs, they're going to be through palpation. So I usually say start collarbone, come out. Once you hit into your AC joint, you're going to want to do piano key, which is your third test there, and you basically just push one side, down side, and you play it like a piano. And your goal is to basically have extra movement on it. So you're trying to destabilize the clavicle on the scap, because it will move more, usually. Okay? Then you can have compression. Okay? Pretty easy. Distraction, you can kind of just pull it or push it, okay, for clavicle movement. Those are your big ones for AC joint. I usually put in sulcus along with my AC. So you can do distraction and feel the AC for distraction, or you can bring your hand placement out a little bit to more your glenohumeral and pull there, and that is your sulcus, okay? And you're looking for global instability, so you're looking for this glenohumeral to translate down more, okay? If you want to be really fancy, you could do the 2-finger positioning, where one finger is on the AC joint, one finger is in your glenohumeral, and you pull and you almost do both at the same time if you're trying to save on time. Make sense? Okay? When you want to do your load and shifts, that's kind of the next one I like to do in this position. You grab your glenohumeral, you stabilize the shoulder, and you give it a little shift. And you're looking for instability. Okay? You can have this same thing and have them, you can also pull and then try to shift. Or you can have them lay back. Whoop. I should go to this side. So you can load into the joint and try to shift. And you can also add distraction at 30 and load and shift. Okay? And do a drawer test. The last one we'll do before we practice is the Apley scratch. So the Apley scratch is a mixture of 3 exercises, and you're looking for range of motion differences, and then you're also looking for pain in the position. So first position is scratching your opposite shoulder, and you do it bilaterally, and you just look for a difference. And then your other ones are switching around, so you're that way. Your other one is scratching behind your back to look for motion, and then you're also looking for up top and scratching up back that way, okay? The other thing that you can call this is a T-test. Does anybody want to work baseball? Like pro baseball? Okay, perfect. Pro baseballers. T-test is the same as your Apley scratch. And basically I want to see, okay, she makes it to, let's say, right about her 6th thoracic. Because remember, your inferior angle of your scap is 7. And then other arm. So this one, now she has 2 vertebrae higher. So she has a 2 vertebrae difference in her range of motion. So as a pitcher, she would get shut down. Because you want to have them equal bilateral. Because if they're not equal or within 1, they're probably at risk for injury. Does that make sense? Okay, so the Apley scratch can be used to kind of gauge shoulder health for pitchers. And it's a very common one along with your external, internal rotation stuff. All right? So let's practice. I'm going to have you just come off a little bit. Okay. So, there's a couple things that this is also for posterior impingement. So I like to stabilize with my leg and then bring them down. Okay, and this one, when you're just bringing them straight down and you're looking for posterior impingement, you're looking for pain back here. Okay, you can also do for pitchers a goniometer test for GERD, where you look for whether their internal and external meet. Okay, for your GERD measurement. If you don't want to do that and you're looking for more of an anterior subluxation, what you're going to do is you can do anterior apprehension, where you crank them and you see if they don't like the position. If they don't like it and you apply pressure to the glenohumeral joint and it feels better, that's called your relocation. And then if you want to be not very nice, you torque them a little bit more, surprise, and it gets worse. That's literally the test. And if it gets significantly worse, then it's a positive test for anterior subluxation. Okay? So those are kind of your big ones for anterior apprehension and then also for posterior impingement. So they kind of co-op together. When you're looking for posterior apprehension, so this is posterior impingement. Posterior apprehension is different. You're going to bring them into 90-90. I like to put my hand underneath the shoulder to feel for the glenohumeral. Translation, you don't have to, but I like to feel that kind of pop back into my hand. You load their elbow, and you press to try to sublux them. And you're looking for movement in that joint. Okay? So when you're looking at your apprehension tests, it's all trying to move the glenohumeral out of alignment. Okay? You're looking to destabilize it here, and you're looking to destabilize it here. Okay? If you're really tall, oh, that's on the wrong side.
Here.
Nope, I got it, this side. If you're really tall, then I like to fulcrum while sitting, and then you can move them this way. A little bit easier. Or you can also fulcrum them this way if they're really bulky, and then you can use your elbow to do the relocation piece. Does that make sense?
So you're pushing it on your left arm?
Yep, so I'm fulcruming on my left arm. My hand is just kind of protecting their shoulder. My elbow is now doing the relocation piece. Okay? So you can kind of do it this way if they're really small and you kind of want to control them a little bit more. You can do it this way if they're big and you can't really move them. Or you can stand up, use your hand, use your leg, and fulcrum them. Okay? So those are the big ones. The next one, if you want to sit up. I don't honestly know how to say this one, and I never really use it that way. This is the F1. F-A-N, or F, Figgins. I never say it. Nor do I really use it. So Figgins is kind of like a sulcus, only with it at 90. You take the shoulder, you keep them straight, then you translate them down. It is not pleasant, it is not comfortable, it's not really that enjoyable. So, you're looking for a shift, whether it's shifting down or shifting not down. Then you have your drop arm. So drop arm is really easy to add into range of motion. So when you have somebody do an abduction, have them abduct, and then tell them to come back out of their range of motion really slowly. And you want to look for this part right here. So supraspinatus in your shoulder is responsible for your first 30 degrees of motion, of abduction. Okay? Then what muscle takes over after that muscle? Deltoid. But that first little motion, that's usually supraspinatus. Okay? So if you're dealing with a supraspinatus issue, what you're often going to see to get the range of motion going is they'll kind of dip and get going. Because that dip will allow them to move that arm a lot easier and get it above their heads. Okay? If they don't dip, they might have difficulty controlling that last end range because that supraspinatus is getting irritated or pinched, or it's just weak, okay? So they might drop it a lot faster when they get to that 30-degree motion. So that's what you're kind of watching, is that last 30 degrees in drop arm. Then you have full can, empty can. And again, this can be part of your manual muscle test. Full can, supraspinatus, pull forward, and a little bit of your delt. Then empty can, you're now causing an internal impingement into the shoulder. It says it does supraspinatus, but if you don't have supraspinatus in other ways, it's going to be an impingement issue, okay? And empty can, okay? Good job. All right.